Most people think diabetic eye disease starts with blurry vision. It doesn't. It starts much earlier, deep inside the retina. Today, Dr. Craig Thomas explains the subtle signs of damage that OCT and OCTA can detect long before vision loss begins, and what you can do to stop it.
Hello, and welcome to the Dr. Kerry Gelb Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you enjoy our interviews, press like, subscribe, share, and hit the bell for updates on new episodes. Great news, our full-length documentary is now streaming on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. And visit my new website, wellness1280.com, for all guest links, resources, and past episodes. And I'd love to hear from you. Reach out to me anytime at drkerrygelb@gmail.com. So now please sit back and enjoy my conversation with return guest, Dr. Craig Thomas. Well, the truth of the matter is only about 30% of the diabetics are controlled regularly. Their blood sugar is regularly controlled. And only 45% is their blood pressure controlled for systolic blood pressure, and only 60% is controlled for a diastolic blood pressure. So people are poorly controlled. This is a very difficult disease to control unless you really take it very, very seriously, and you're on a no carb diet, you're doing intermittent fasting, you're exercising and doing all the things that you're supposed to do, and you're on the right medications that can help get the blood sugar out. And we'll talk about some of those later, and we'll talk about some of the supplements later. But you were one of the first doctors, I remember listening to your lecture, talking about peripheral lesions, peripheral hemorrhages. One of our good friends had a peripheral hemorrhage, and I'll tell you the story. And he came to me, he says, I have a peripheral hemorrhage. He's a doctor. One of his doctors did a peripheral retinal exam on him, and they found these peripheral hemorrhages. And he went to the retina specialist, and the retina specialist says, "Oh, you have nothing to worry about. There's nothing that you have to do at this point. You don't have to change anything. You don't have to do anything." And nothing could be further from the truth, what we know now. So talk about those peripheral hemorrhages that we see sometimes, and what does that mean?
Well, I agree with you 101%. That is part of historical diabetic nonsense. I guess we could call it that. Okay, because and again, I'm guilty. I'm because that's what we were taught. If I didn't see bleeding at the macula, I'm like, hey, bro, you all right? See you next year. I'm serious. I mean, that's what we were taught.
Right.
And if there was
There's no treatment, we don't need
yeah.
to treat, but the treatment is lifestyle.
Yes. Oh, absolutely. So what we know now, okay, now because we got all these fancy Optos machines and wide field imaging, and now we're seeing it. Again, I'll admit, man, I'm like 30 exo. I have no binocular vision, and when I try to do BIO, I can't see nothing. Okay, so I spent years just kind of dependent on fundus photography to see out in the periphery, and I'd have like a 45-degree Polaroid camera, and I'm like, okay, he looks good. Okay, what we know now is that almost 40% of vascular lesions, bleeding in the eye that you can see with an ophthalmoscope. Okay, base level, entry level. Okay, this is entry level diabetic retinopathy is in the periphery, almost 40% of the lesions. So again, if you just whip out a direct scope, look through an undilated pupil and glance at the macula, and you see a bright reflex, and you go, this guy's fine, this lady's cool. Okay, see you next year. Okay, that ain't how you do it. Okay, because you're gonna miss 40% of the lesions if that's how you do it. If you take a cool non-mydriatic fundus photo, like a lot of eye doctors that I used to know did, okay, good for you. Okay, you're going to see 60% of the stuff, but you're going to miss 40%. I mean, there's no recommendation that we would go by where we have a 40% failure rate. There's no drop that I give people where I'm like, hey, I want you these drops 4 times a day, and they're gonna help you 60% of the time, but 40% it's a failure. There's nothing we do like that. Okay, so if you don't know what you're doing and why, you're gonna miss 40%. You're gonna make the wrong diagnosis 40% of the time. And if you care about what you're doing, and I do, and hope everybody does, you don't want to do that. You want to do your job properly. And part of doing it properly, you got to know why, and what you're looking for. So the big thing, you got a whole bunch of lesions out in the periphery. And the second big thing, and this is a big thing, is that once you see these bad boys out in the periphery, it's all bad because they're like the harbinger of doom almost. You got this significantly increased risk of progressing to proliferative diabetic retinopathy. And to me, then all the associated cardiovascular events that go with that, like stroke and heart attack. And so once you see stuff out in the edges, it's all bad for the patient. And to me, I kick it up a notch on what I do, all my discussion of modifiable risk factors and monitoring and supplements. I'll go heavy on supplements because I read this article. I read this just a couple of months ago when I was doing this presentation, getting ready. And it is this quote this guy wrote on there. He says, we're trained to kind of focus on the retina, focus on the macula, look for macular edema, look for bleeding, because that's the most important part. But when you have diabetic retinopathy, the whole retina is sick, not part of it. It's the whole retina. And you got to look at the whole retina. Okay. And if you're going to treat it, and not with some focal laser or some intravitreal injection, then I'm going to treat it through nutritional supplementation in the blood system where I can get at the whole retina. That's
It's
how I
not,
look at it.
and it's not only the whole retina, it's the whole body.
The whole body.
We can see the blood vessels in the eye, but we can't see the blood vessels in the kidney. We can't see the ones in the brain. We can't see them in the heart, but we can see them in the eye. And if we could pick it up here and prevent, we could prevent what's going to happen in the chest later on. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MySight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. We were talking before that we could see now with the new technology about 8 microns, and there's technology that we can see at 1 micron. The human hair, I wish I had some, is about 70 microns. So that's how small that we're able to see. I like to talk about OCTA. You talked about it before. OCT angiography, that's what the A stands for. And we have the superficial capillary network, we have the deep capillary network, and we have vascular density, capillary dropout. So when we're doing OCT angiography, explain what we're looking for and what that tells us.
Well, the OCT angiography is looking at the blood vessels and the blood flow, and then looking at tissue perfusion, the density of the capillary network within the tissue, bringing all the oxygen and metabolites to the cells in the tissue. And what the modern OCT machines do, I've had 2 of them. I don't know about the rest. I'm assuming they're all similar. They've got algorithms and computer programs in there that produce what's called these vascular density measurements. So we can actually have numbers like looking at a visual field. And you can look at different quadrants of the retina, different sections, and determine, is the vascular perfusion normal or abnormal for this part of the retina? And what the studies indicate is that this decreased perfusion is a direct reflection of physiology and the health of the tissue. And once you see the blood flow going down, basically everything starts to go down as far as function. And if we're talking about retinal function, we're talking about seeing. So once the retinal function starts to go down, contrast sensitivity goes down, color vision goes down, eventually visual acuity may go down, but that'll be right at the end. All the other stuff's going to change first. So you're looking at the blood vessels almost at a microscopic level, and you're looking for abnormalities that you can't see with an ophthalmoscope, but that are, to me, just as clinically significant. Just because I can't see it with an ophthalmoscope doesn't mean it's not there. And to me, it's actually more important because I'm making an assessment earlier in the natural history of the disease, where if I want to do something about it, I got a better chance of making a change. So that's the biggest thing with the OCTA is looking at stuff you can't see with the ophthalmoscope, and then understanding what you're looking at and what it's telling you. And again, if I'm seeing decreased retinal blood perfusion and decreased retinal blood microcirculation, it's probably in the kidney, it's probably in the heart, If it's in the retina, I know it's the brain because the retina is part of the brain. So when I see bleed, if I see microaneurysms on an OCTA, I'll tell the patient that their brain is bleeding, and I'm not trying to scare them. I'm telling them the truth. And I said, look, if we don't stop this, I said, I'm telling you, there's a thing called diabetic encephalopathy. Are you familiar with that, Kerry?
I am.
Okay. Some people get kind of silly when they get diabetes and they start making bad decisions because their brain's all messed up. Okay. They get a little goofy. Okay.
And and it's interesting because these little capillaries, once affecting, we're seeing these dropouts of these capillaries or these little pouching, these microaneurysms in the eye. And that's at the same time, men could start having trouble with this sexual function.
Anywhere you've got, small blood vessels, if you've got small blood vessel disease, well, it's going to affect the function. And there's certainly small blood vessels everywhere. Again, it's just easy to see right here, but it's not localized to the retina or the eye. The damage occurs throughout the body, as you've already stated. So that's what's so cool about this is I do these scans and just time after time after time, and I've got a fancy top of the line, brand new Claris fundus camera. This thing's crystal clear, and the images will be crystal clear. And I'll do an OCTA scan and see all kind of stuff. I'm like, wow, that's crazy. you know.
And there's part of the eye, the center called the macular, and that part's affected also. And that we could see swelling there, and there could be no bleeding in the rest of the retina. Talk
Oh
about
no, yeah,
diabetic macular edema.
no, there's no rules. That see again, 20 years ago, I'd have had the person with 20/20 vision, and I'm like, there's no way there's anything wrong with that guy. Now that guy could have clinically significant diabetic macular edema that I could only see with an OCT. He could have retinal neurodegeneration that I could only see with an OCT. He could have decreased retinal sensitivity that would only be picked up on a 10/2, not a 24/2. He could have decreased color vision where you got to have cone contrast sensitivity testing, not some kind of worthless D15 test or some kind of Ishihara color plates. Okay, you could pass that upside down. So you got to right technology. You got to have the right knowledge base. But the easiest part is all the patients. Okay, the 30 million people with glaucoma, I mean, diabetes, there's plenty of patients. So once we get our part straight, then we can help all these millions and millions and millions of people that are losing their vision. Carrie, have you heard about this Mary Tyler Moore Foundation?
I have. She was a
I started reading their stuff.
right,
Man, it's
right.
pretty cool.
And what have you found out about it?
Well, I just started I about 3 months ago. I ran up on it when I was doing just researching articles, and I saw some of their stuff. I was just really impressed with it.
Yeah,
You know, the,
they raise a lot of money for diabetes prevention. And
yeah.
she was a very bad diabetic, Mary Tyler Moore. And
Yeah, so yeah, but I mean, just this, they're talking about the stuff you and I are talking about. They're talking about neurodegeneration. They're talking about nutritional supplementation. They're talking about subclinical disease. They understand, and I was just impressed with that. Whoever's advising them, they know exactly what's going on.
oh yeah, they're on the cutting edge.
Yeah, they're right on the edge. Yeah, very impressive. Yeah.
You were one of the first to talk about diabetic retinal neurodegeneration. And I want to go into that in some detail because a lot of times that'll happen before the vascular changes happen, before we see the bleeding, and before we see exudates in the eye. The diabetic neurodegeneration is going to happen before that. Talk to us a little bit about that and about what causes it, about the retinal ischemia, and how and about some of the nerves dropping out and the different layers of the on OCT. We can see different layers where the nerve fiber layers are dropping out. The ganglion cell layer is starting to get thinner. Talk to us about that.
Well, I started seeing this probably 15 years ago. And I almost remember the very first the alpha patient was a lady came in. I've been seeing her for years, and she just came in saying she couldn't see good. My you've heard me lecture. My favorite chief complaint is I can't see right. So she said she couldn't see right. I did a refraction, and she was like 20/25 minus. but she was definitely not 20/20. I dilated her up, looked in there, I couldn't see a thing. Did a visual field. It was kind of goofy, but it was an old field. Who knows? Just back in the old days. And then I did the OCT scan. I just got my brand new OCT, and the OCT was all red and showing that the retina was thin. And I'm like, what is this? Why is this? I'm not. What's causing this? What's going on? But it was real thin. It still had the foveal depression and everything, but the whole retina was just thin. Uh, and so I'm like, I wonder if this thin retina is associated with this 20/25 minus vision in a lady that used to have 20/20 vision. And then I kind of started reading up a little bit. And I remember back then, the reference I found, the number was 18 to 20% of people with diabetes had this atrophic neurodegeneration thing that you could see on an OCT scan. I'm like, that ain't 5%. That's a lot. And the more I started running OCT scans on people with normal looking retinas, because from the beginning I didn't do that. I was waiting for the eye to start bleeding, and then I just run the OCT scan to see how bad it was. So then I started running OCT scans on people that had normal appearing retinas, and lo and behold, every third, fourth patient, would have a thin retina. And I'm like, okay, there's a connection here. So that's how I started it. Then I started reading up on it. Then I started lecturing on it. And even as recently as, again, a few months ago, I was reading some articles on it. And the biggest thing, and this is what I thought, is the biggest mechanism of action appears to be this ischemic process. So ischemia, lack of blood flow. You've got the diabetes messing with the capillaries, all that endothelial stuff. Remember reading about back in basic science. So you've got obstruction of the vessels. The blood's getting, kind of not getting to the tissue. So we call it ischemia, when the tissue is not perfused with blood adequately. So this chronic ischemia that you cannot see with an ophthalmoscope damages the tissue over time and slowly damages the glial cells and some of the other structural cells in the retina, the photoreceptors, and the retina just starts to shrink. It just gets thinner and thinner and thinner as the tissue starts to die. And remember, regular OCT scanning is essentially a measurement of retinal thickness, and then we kind of make an assumption and correlation that a healthy retina is a thick retina, a sick retina is a thin retina, a sick retina could be a big fat retina, but all we're measuring is thickness, mostly. Once it starts getting thin, then, well, that's an atrophic process. That's a neurodegenerative process. We're not talking about the skin getting thinner. We're talking about nerve tissue getting thinner. Okay. It appears to be the primary mechanism is ischemic, is what it appears to be. And then I actually read an article where it said, and I read two or three without getting too geeky, just talking about the effects of hypoglycemia, specifically on the retinal nerve fiber cells, and how just the hypoglycemic environment just damages the tissue and messes it up. So, you've got direct kind of almost caustic effects of high blood sugar combined with decreased blood flow. That's what appears to cause it most of the time.
Yeah, and we're getting inflammation, oxidative stress, loss of mitochondria.
Well,
So,
that's all downstream once everything starts to crater. So then it's like then you get the loop, once the inflammation starts, once the oxidative stress starts, then it all starts. And until you do something, it's just going to keep on rolling.
and
Now, I will.
I was going to say, it's really important that people look for this if they're pre-diabetic or, of course, diabetic, because about a quarter of the people, this will happen before there's any vascular changes.
Oh, absolutely. Well, again, almost to me, that's a good point, because you could certainly have vasculopathy and neurodegeneration existing at the same time. I'm really focused on the neurodegeneration in the absence of vasculopathy, where the retina looks normal. If the retina is bleeding, I already know it's messed up. And all I'm going to do is run tests to see how bad it is. When it looks normal, I'm running tests to see if it's bad. That's a difference.
And when
You know,
people have this neurodegeneration, they're at risk for Parkinson's, they're at risk for Alzheimer's, they're at risk for cognitive impairment, all these things that you brought up before.
Everything goes down. That's why it's so important to keep it from going way down and
When you
identify it early.
encephalopathy,
Yeah.
inflammation within the brain, because they start getting cognitive impairment, they get brain fog. people have this brain fog and they can't think.
Well, it's so common with the patients with glaucoma. I mean, it's almost laughable. You ask the person, "Hey, you taking your drops?" No, I forgot. Hey, you taking your drops? Yeah, maybe. I mean, it's ridiculous. It's like people taking their high blood pressure medicine. You take your pill? Yeah, I feel okay today. I didn't take it. Well, that's not a good decision. You're making bad decisions. Maybe your brain's messed up. Okay, you got bad diabetes. Stop it. Let me put you on some supplements. So that's
Well,
how I look at it, man. And then what I was going to say, I don't know if this is the right time to jump this in, but talking about all the oxidative stress, the chronic inflammation, specifically the mitochondrial dysfunction. I do lots of lectures on ocular surface disease, meibomian gland dysfunction, and the mitochondrial dysfunction is a big, big element in the pathophysiology of that condition. And what we're seeing, you see how the Lumathera device got approved in January for treating macular degen with the red light. Kerry, I'm starting to do that off label.
you
I've
are.
got, yes, I am.
You have
I've got,
Lumithera in your office?
no, I got the MD Elite photobiomodulation technology that I do for the eyelids. And so I just turn the power up. Okay. I mean, it's totally off label.
Uh-huh.
Uh, but I've had a couple people with some pretty significant improvement.
Really?
Okay.
And
Yes.
when you do it, are their eyes closed or open?
Yeah, yeah. Closed eyes. Yeah, closed eyes. I had one lady. She went from 2060 to 2025 after 8 treatments.
No kidding.
Yeah, I'm serious. I'm
Wow.
serious. I had one lady, she really did, you didn't see it in the acuity. She was here for we do 10 treatments, and she was here for like her seventh treatment. And I just saw her sitting out there, and I said, "Hey, how's it going? Are you seeing any better?" This lady's got diabetic retinopathy, glaucoma, macular degeneration, best corrected 2200. I've been telling her for years there's nothing we could do. Okay. Nothing we could do. Just trying to keep the pressure down. There's nothing we could do. I did these treatments on her. I saw her sitting there for the seventh, eighth treatment, just waiting to go in the room, in the treatment room. I said, "Hey, how's it going, Dorothy?" And she said, "It's good." I said, "Are you seeing any better?" She smiled from ear to ear, and she said, "I'm seeing a lot better." And I'm like, "For real?" And she goes, "For real, for real." I go, "Describe it." She goes, "Well, I can see the TV a lot better. I can see people's faces on the TV. I can see people's moving, the lips moving. I can tell people when they walk in the room. I can see who it is before they get up on me." She says, "I haven't had a breakthrough in the reading yet. I still can't read good." But she says, "All the distance is much better. When I'm driving, I can see around." She was thrilled, just thrilled. And I'm like, wow. I mean, now I've had two or three where it did nothing. Okay. Where I've
Do you
seen
do
them
it
and no
twice
better.
a week? Are you
You
doing
do
it?
it twice a week for a month. So you do 8 treatments the first
And
month,
how long does it last each treatment?
18 minutes.
18 minutes. And where did you pick 18 minutes from?
I got it from this guy, Dr. Brothers, who figured it out. He developed his own protocol. So there's probably more than one way to do it.
Is that what Lumithera, is that on their studies?
No, no, no. So, Lumathera won't sell to optometrists yet.
I
So,
know.
I mean, it's like, okay, fine. I got plenty of people with macular degeneration. I'm just trying to help them. It'd be nice if you saw me the machine and I try to help them with that. But if not, I'm gonna still try to help them. And what I'm seeing is that photobiomodulation therapy is photobiomodulation therapy. That's what I'm seeing.
And
Uh,
what's the name of the machine you use again?
just well, it's the device. I got it from a company called MD Elite, but
MD.
there's several devices. If you Google it, man, you'll see it. It's all over Europe.
Right.
Uh, yeah, yeah,
I was
yeah.
trying to get one of them on my podcast, but I
Yeah,
couldn't
as a matter of fact, I actually
get
read,
one.
I looked at a pretty good internet presentation by these guys in Italy about 4 months ago when I started thinking about doing this, because they're doing it with the Espansione mask unit, which I have one of those too.
Right.
Uh, so I've got two IPL devices, two radio frequencies, two low level light therapies. I got two of everything. So I've got the mask. I bought it 5 years ago, and they're doing the same thing with the mask. Just turning the power up, using the red light. It goes through the eyelids. And again, the whole reason I mentioned this, I got off on a tangent. I'm sorry, is that because the pathology, the pathophysiology is the same as with other parts of the body that get messed up, is especially the eyelids, talking about stress and inflammation and mitochondrial dysfunction. So the same thing that can make your eyelids better with exposure to red or near infrared light can make your retina better. That's what the Lumathera guys have proved. That's what they proved in Europe the past 3 or 4 years. Again, I'm dabbling in an off-label procedure, but I kind of wanted to see, and I mean, what I'm seeing has been pretty positive for some people. So I now believe that there'll be a future where we may start treating people with diabetic retinopathy with red and near infrared light therapy. And I've got several people that
And
I'm
that's
starting.
a mask that you're using? You're using the
Well,
mask?
I have both. I can do it with a mask. I can do it with panels.
Which way are you doing it mostly?
The panels, because
Panel.
I think you need a software update on the Esponzione unit to do it, and I hardly ever use that machine anymore. I use the panels mostly, so I wasn't going to mess with it, and it seems to work. But what I again, my point is there's more than one technology that can do this.
Yeah.
Okay. Now,
Wow.
right now, you've got one technology that has FDA clearance, and so you got to go with the lead dog as far as talking about it. If you're going to talk to patients, if you're going to try to do something else, you got to mention right up front, hey, we're doing this off label. Is that okay with you? And I always say that. Uh, but yeah, I'm hoping there'll come a day where there'll be more than one device, and every regular eye doctor can do this in their office, just like every regular eye doctor fitting contacts or prescribing glasses. Once you understand it, you can deliver the therapy safely, effectively. It works pretty good most of the time. If it doesn't work, you really can't hurt nobody. The worst thing you can do is burn their skin, and they'll complain if it's burning, then you just stop. So it's a low risk procedure with potentially high benefit. And I've seen two people where they're ecstatic. Now that, I've seen three or four where nothing happened, but I'm willing to take those odds where before I was just saying, hey, there's nothing we could do.
Now, are you seeing changes in the morphology of the retina?
Yes, the first lady I saw changes. You could see it. We
You,
scanned her with the OCT. You could see the drusen shrinking. You could see
oh,
it. It was crazy,
that's unbelievable.
crazy. I wouldn't have thunk it.
You were one of the first with ERG. Tell me about ERG, why that's important, and why people should get an ERG when they're diabetic, as far as helping us with progression for diabetes, AMD, glaucoma.
Well, the ERG is another piece of the puzzle. If I'm talking technical to doctors, I'll use the correct terminology, which is domain, where I'm testing visual function in different domains. So one domain would be Snellen visual acuity. A different domain would be retinal sensitivity you pick up with a perimeter. A third domain would be color vision testing. A fourth domain would be contrast sensitivity testing. A fifth domain would be dark adaptation testing. A sixth domain would be electroretinography testing. And they all look at different structural components of the eye and retina. So they'll tell you different things if they're abnormal. The ERG, especially the flicker ERG in particular, is real sensitive for picking up retinal damage that's induced by diabetes way early. So again, we kind of keep saying the same thing. You can have a person with 2015 vision, dilate them up, see absolutely no vascular lesions. Okay, so they look normal, they see normal, and you could run an ERG and it could be abnormal. That person has functional diabetic retinopathy. Okay, it's a new classification. If we went by the lame 25, 30-year-old classification, they're normal. We'd fill out some piece of paper, send it to the primary care doctor, tell them that our mutual patient is normal. We're lying. So now we're making the wrong diagnosis. Now the medical doctor thinks that he or she is doing a good job because we just told him that the person doesn't have any ocular complications, when if we look better, we would see it. So it changes everything if you did an ERG and it's abnormal. The person has functional diabetic retinopathy. If the ERG is abnormal, the person has diabetes, and you don't have anything else that would be causing that ERG to be abnormal, like a stroke or diabetes or something else going on. Okay. And that's why it's important. It's no more or less important than any other test. They're all the same to me. Visual acuity is the same as ERG. ERG is the same as color vision. Color vision is the same as retinal sensitivity. I don't do one and call it a day. I do three or four before I say the person's normal. Because you could be normal in one or two and have the next two messed up. And unless you do four, you don't know that. You got to look at the whole thing and test the visual function in more than one domain, just like you're evaluating structure in more than one domain. You're evaluating it with an ophthalmoscope, and then you're going to evaluate it with an OCT. You might evaluate it with a multispectral imaging device. You might evaluate it with an OCT angiogram. If you're a retina specialist, you might evaluate it with an intravenous fluorescein angiogram. You can evaluate structure 5 different ways. Nobody talks about that being crazy. We can evaluate visual function 6 different ways. And since I'm the best optometrist in Dallas, that's what we do.
Well, tell me about color vision since you brought it up. There's studies that show it can be abnormal 42%, 40% of the time
Yeah,
before you get vascular changes.
color vision is real sensitive as far as visual function. And I've got 3 or 4 articles that all say the same thing. If you got a bunch of people that had diabetes 10, 15, 20 years, you line them up and do sophisticated modern cone contrast threshold testing, and there's 3 or 4 devices that do that. Okay, then you'll pick up all kind of stuff. Okay, if you just do it properly. And again, person has glaucoma, if they've got macular degeneration, if they had a stroke, they got a brain tumor, if they got a bad cataract, if they got corneal opacity, okay, there's 7 things that'll make the color vision get messed up. But if you don't see any of them 7 things, and you got a person sitting there with diabetes for 10 years, then they have functional diabetic retinopathy if the color vision is abnormal. Okay, and then you go from there. And once I see that, okay, then I'm like a bird dog now. If you got abnormal color vision, I'm like, what else is messed up? Hey, Susan, I need a 10-2 visual field and an ERG and contrast sensitivity testing on room 4, please. Let me know when you're done. Okay, I'll walk away. Then I'll come back when they're finished. Then I'll tell the person you're okay or you're not. Because until I have all the information, I don't really know. I'm just hoping.
And how about one of our old faithful visual fields?
Well, man, I added up. I bought a new visual field last month. I got me a new headset, and I'm actually playing with the objective field right now. It has some pros and cons. I kind of like it. I did 668 visual fields last year. I
Wow.
don't know if that's a lot or a little, but I'm blasting with the fields. Okay, I did 668, and I'm looking to increase that number this year.
Yeah.
Because I got 2 of them, man. Yeah, we going. As a matter of fact, I had 2 headsets. I just sent one back, so now I've got a headset and the objective field. So I've still got 2 perimeters in the office. And I looked at my numbers 2 days ago. Man, we're up to 400 and something fields this year
Mm,
already. So I mean, at the rate I'm going, I'll bust 800. So maybe 100, 150 more than last year. So I mean, I'm doing some visual fields. I mean, that's other than OCTs, that's how you're going to get the most information. You just got to do fields on. If somebody got a hangnail, I'm doing a visual field on them. Okay. if you have diabetes, you got a pretty strong chance to get the 10-2 visual field in this office because I don't know if you're normal until I do it.
right, right. And the macular edema, it's going to pick up macular edema, early stage diabetic retinopathy. It gives us a lot of great information.
Well, I generally go, I go OCT, OCTA, 10-2 visual field. If all those are normal and the person's got 20/20 or 20/15 vision, I'll generally call it a day. Okay. But I won't call it a day till then. If anything is abnormal, then I add in color vision, ERGs, maybe repeat testing a week or 2 later. So I'll do a 10-2 field, OCT scans, dilate them up, look in the periphery. If those things are all normal, okay, I go to the next patient.
What do you think about OCT as a screener?
Oh, it's, I got to tell you, it's the way to go. You can't, I've been trying to say that indirectly for an hour. You don't come in this office with diabetes and not get an OCT scan. I don't care about your insurance. I don't care about paying for it. I don't care about your deductible. I don't care about nothing. I don't ask you. I'm telling you. And I don't care about the little rinky dink $50 that I ordinarily would charge for an OCT scan or whatever you charge. I'm not telling people what to charge. Charge $5, charge $100, whatever you charge. I don't care. The OCT is bait. It's a bird dog. I'm the hunter. If you never grew up hunting, you don't know what I'm talking about. Okay, I grew up hunting. You
How
got
about
to have a dog
on
to
a
find the
non
birds.
a routine? Someone who's coming in for a routine. Do you do an a screening OCT on everybody?
Yes,
You do. All
if they
right.
have diabetes.
No, if they don't have diabetes, they don't.
No, no, no,
No. If they don't have diabetes, it's a routine.
no.
You're not doing a routine. Talk to me.
No, unless I mean, I go by some guidelines. If they high risk, I got a big person, I got a mature person, I got a person with pre-existing vascular disease, primarily blood pressure, because if they got glaucoma, I'm already testing them. So if you mature, look unhealthy for whatever reason, and you got pre-existing vascular disease, you get a scan. Okay. But that's probably the only non-diabetes group I would do kind of routinely where I'm just doing it. But if you got diabetes, this part of this, pressure, autorefractor, fundus photos with the Claris, OCT scan, then they go in the room and I walk in. All of that stuff sitting on a monitor when I walk in the room. Because all I'm gonna do is make them do it when I walk in. So they've been trained to save time, not move the patient around. They know if the person got diabetes, get me some fundus photos with that Claris, wide as you can. We can do a mosaic through an undilated pupil. Okay. I can go out to 110 degrees through an undilated pupil. It's not 200 degrees, but I can go 110. So I get that. They get an OCT. If they could sit still, we get an OCTA. If they move, it's hard to get it. But we at least get an OCT. And we do all the scans. We do ganglion cell, macular, optic nerve. They're sitting there. Might as well do them all. Get them all. And then I've got big flat screen monitors in every room, big 40-inch flat screens. When I walk in the room, those images are populated on that screen, and that's how I start the conversation. Either like, hey, everything looks good. Let's get your vision checked. Or if I see anything, we start focusing on whatever I see that's abnormal. So that's how I go with that. Everybody can develop their own program, but I found that the OCT is just too valuable. And since I know about subclinical disease, whether it be neurodegeneration or subclinical vasculopathy that can only be picked up in OCTA, then again, I'm not going to wait for the person to complain. I'm not going to wait for them to say, I don't see right. I'm not going to wait for their eye to start bleeding. Them coming in with the medical history of diabetes sets everything in motion for the screening part. Now, again, I'm not trying to work for free. If somebody's got a good insurance or they driving in a nice car, they get ready to pay for it. But if they're poor and they ain't got no money, I'm not going to deny that benefit to me because I need to know. Sure. It's just too important. And since I'm not doing the work, I don't really care. My staff's doing it all.
And how about pupils? You were one of the first, or very early on, pupil testing, sophisticated pupil testing. Talk to me about that.
Pupil testing doesn't really come in heavy with diabetes and diabetic retinopathy because most of the neurodegeneration is symmetrical. And the pupil test always measure clinically significant asymmetry, like you would see with primarily glaucoma. So I usually don't incorporate that into my clinical decision making or my battery of testing because it's usually going to be normal. It's not going to show me anything as far as diabetic retinopathy because again, from a functional point of view, most diabetes-induced functional vision loss is symmetrical most of the time.
But it does affect the pupil. People have trouble, it's hard to dilate, diabetics.
Oh yeah. I'm not going to say it doesn't affect function, but in the sophisticated computer-assisted pupil testing that I do, because it takes 3 or 4 or 5 minutes. I mean, it's not just a casual thing. I mean, they got to set them up and do it.
Right.
So to answer your question, I don't do it a lot for a diabetes indication. And I haven't found any significant clinical benefit there yet.
Something that's very confusing to patients. A lot of patients have vision insurance and they have medical insurance, and they don't have to deal with this when they go into an internist office. They have one insurance and that's it. But when they come to the eye doctor, they have more than one. They have a vision plan, they have insurance, and patients are confused. Even the doctors are confused. So this is something that you've given a lot of thought and you've studied a lot about. Tell me about vision insurance and what happens to the patient. Are they getting lost in the insurance nightmare between the vision insurance and medical insurance, or not really vision insurance, but really discount plan?
Well, here's the first part. Eye doctors, especially optometrists, have a particular conundrum where you have to navigate multiple types of insurance benefits for the patients. A lot of doctors don't have to do that, but a lot of us do, and optometrists in particular have to do it a lot. The what I have seen is that we are not alone. Fortunately, I guess, misery loves company because I've seen many cases when people go into their medical doctors because It's not just us. It's medical insurance too. It's just they cover it up different. In medical insurance, you've got like a routine mammogram versus, there's something wrong with my uterus. You've got a routine physical versus, hey, I broke my arm. Okay, where the routine may be covered with no copay, but if I break my arm, it's $200. So they've got the same differentiation, but it's all within one plan. With us, it's two different plans always. That's the big difference with medical doctors. I've seen it, man, where they'll, it'll be some lady going in there for a routine well woman check. They bill the insurance $150, and then she says she got something wrong with her. Then they go medical, and they bill both visits the same day, and they get them paid because I've seen it. Okay, we can't do that. If we do that, one of it's like our guys talk to each other. Man, if I bill a visit to a vision insurance and their medical plan, I'll get a letter 3 months later saying I want some money back. Okay, and that's every time. And it's always a mistake if we do it, but they always catch it. Okay, they talk to each other, whereas it doesn't happen on the other. So that's the first thing is that we're not alone. Okay, the
Well,
second part,
let me just
yeah,
interrupt for a second. How does that affect the patient? You just mentioned a case where they had vision done and medical on the same day, and then you get a letter that you have to give money back. How is that? How does that hurt the patient?
it doesn't do anything to the patient. It doesn't. It only hurts me.
What number of people in the US have some type of vision insurance? Have you had a guess?
If I had to guess, 40, 50%.
40, 50%.
Yeah,
That's right.
yeah.
So we talked about before about supplements, and I left it for last because everybody's interested in supplements, and I want to give it the due time that it needs. So tell me about supplements that you're interested in. Before we talk about that, I just want to mention a little bit about some of the medications that the endocrinologists are using very successfully, the SGLT2 inhibitors. And people, those are very interesting medications because they actually cause the patient to urinate glucose. So it's actually taking glucose out of the body. And it shows that it decreases heart disease, heart failure, less risk of going to the hospital for heart failure, kidney disease. And people have done well with those. Invokana, Jardiance, Farxiga, those are the common ones. And we're seeing more and more people on those. And
Me too. All day, all day, all day.
and the other one is the GLP-1s, which have really become the receptor agonist, the GLP-1 receptor agonist, because of weight loss. And people are losing weight on these drugs, the Ozempics, the Wegovy's, Rybelsus is an oral one, Victoza was an old one, and it's also shown that there's about a 10 to 15% decrease in major heart problems and kidney problems. But, of course, any of these medications, there can be some side effects. And I was just wondering what your experience is seeing people on these new medications, the SGLT2s and the GLP-1 agonists. My experience is that people have done very well. Now, there are reports of with the GLP-1s with macular edema. There's been some reports, some problems with the nerve of the eye, but in general, most people do well. But I just wanted to see what you thought about it.
Well, the biggest, most striking thing is the weight loss. I've seen people that I've been looking at for years where they're, big as a house, and they'll get on these new meds and they'll come in, they'll drop 40 pounds in 6 months. I mean, just like boom, it's crazy. I've seen that dozens of times. I'm just now becoming aware, just I'm pretty busy. I mean, I try to keep up, but I've seen a couple of reports of the retina problems, with some of these new meds. I haven't seen it clinically yet. And again, everybody's taking these things. I mean, yeah, I see somebody on metformin. I look at him like, "Where are you going? Who's your doctor?" Like it's like you might as well be taking peppermint candy. So almost everybody that's has a good doctor is taking these modern meds. I'm a little curious about the small incidence of retinal complications in a small group of people, but I'm not I don't care about it too much, but I'm curious about it because I've heard about it. I haven't seen it yet. To me, it's all positive. I, the weight loss thing has been so dramatic when I walk in the exam room that you almost don't talk about the diabetes control. Where ordinarily, I'll be, hey, how's your blood sugar? How you check it today? I'm looking at them like, hey, man, you lost 40 pounds. What's up? That's how the conversation's going, most of the time. So it kind of, and it's like, yeah, I got on this Ozempic, blah, 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 and I'm like, okay, keep it up. So and those people, what it has done as I sit here and reflect on it, talking to you, it's diminished all my other conversation. So all my conversation about would you have for breakfast? Did you do any exercise this week? All that stuff that goes down when they've lost 40 pounds.
I think one of the things that people have to be careful, Monjero is another one, is that there's alternative markets to get these medications that are non-FDA approved medications because the medications are very expensive and people are looking for alternatives to buy it. And you'll see on Facebook or on the internet somewhere an alternative place to buy it where supposedly it's the same medicine, but you really don't know if it's the same medicine. And is that what's causing the side effects? Is it because they're getting it from alternative places?
I would think not, just off, just my initial thought, because it's in the literature. And
Right.
and I think they would have, if that was a variable in the equation, they would have already figured that out. So, and commented on it. So I don't think so. I actually had one lady this morning, you talk about cost, because I asked people, I say, how much you paying for that stuff? And she's like, well, I'm getting this injection and it's 4,000 a month. I go, is your insurance paying that? And she goes, no. I go, well, how are you handling that? She goes, well, my doctor got this special coupon thing for me and I had to go through this program and they're doing it for me. And it's, what it reminded me of us going through the nonsense trying to prescribe some Xdemvy or something,
Right.
or some Mibo drops, or Oxervate, where you got to jump through all these hoops. So that's the way she was getting it. She said it was 4,000 a month.
Holy Toledo.
Yeah.
Crazy. So let's talk about supplements. What are your favorite supplements? I just want to just bring up that there's been some studies on omega-3s. I think it was out of Spain. The pre-Dimed study showed that 500 milligrams of omega-3s, you had a 50% less likely of sight-threatening retinopathy. There's the MESA study, and that also showed there was about over 50% chance of severe diabetic retinopathy. Fenofibrate, which is a medication used for triglycerides, Tricor, has shown to decrease macular edema. If your triglycerides are high, you're at much greater risk of getting macular edema from diabetes. But where are you on the supplements?
Well, I go to supplements when I see vasculopathy at an early level. I mean, if they're proliferative diabetic retinopathy, give her to have a vitrectomy, okay, some vitamins aren't going to really do anything. But if I see early disease or subclinical disease in particular, I explain. Look, I use two products. I use the I Promise version, the DVS diabetes vision support, and I use the formula from Science Direct. They're a little bit different, and I just kind of pick and choose between what I think they need. I'm most familiar with the I Promise version. That was the one that was original, from the DIFA study, that thing Paul Chouse did with a couple other guys. It's probably 10 years old now, but they proved that people can get improved visual function by taking nutritional supplements if you have diabetes. They proved it. Okay, I don't need to prove it again. I believe them. I mean, it was in the British Journal of Medicine. Okay, I mean, I believe it. Okay, or BJO, British Journal of Ophthalmology. Uh, and so I believe in the science. I believe in nutrition. I'm a holistic guy. The medicine is just expensive drugs. Drugs are just chemicals. Chemicals are just a bunch of ground up rocks. Okay, it's just a bunch of chemicals. So I do believe that in a subset of people with diabetes, they have potentially significant benefit, and I always offer them to that subset of people. Somebody I'm getting ready to send to a retina specialist to have an injection or some laser surgery, we're too late, to me. Uh, But anybody that's early, anybody that I'm managing, anybody where I'm telling them to come back in 3 months instead of me sending them to the retina specialist, anybody without clinically significant macular edema, I'm offering supplements, and we sell them here in the office because I believe in them.
And
Yeah, yeah.
how about, well, the diffuse supplement has omega-3s in it, and you do separate omega-3s for it.
I do the Science Direct version with that gamma linoleic acid,
Mhm.
for my omegas. I do keep some Nordic Naturals here for just pure omega-3, the old kind, the regular kind, but I don't like the fish burp. With the Science Direct version, you don't get hardly any kind of fish burp. And the gamma linoleic acid is supposed to be a little bit better, with controlling inflammation, supposedly. So, I use omega-3s primarily for ocular surface disease. If I'm going to go with diabetic retinopathy, I use either of those two formulas, either the Science Direct formula or the one from I Promise.
Yeah, and Macular Health has a good one as well.
Macular Health has one too.
They
They
have a
do.
good one,
Yeah.
theirs has vitamin E, chromium,
Yeah. You're
magnesium.
right.
Then they have
What's our homeboy's name? The French dude?
yeah, Frederick.
Yeah.
Great.
Yeah, they got one. They got one too.
His supplements are great. His
Yeah.
supplements for decreasing macular degeneration is great. As we're wrapping up here, is there anything that we didn't talk about that you'd like to talk about to tell the audience?
Just no, I mean we've covered everything pretty well. For the people that are listening, I just, it'd be nice if me and you and all the doctors and people trying to help had more help. We need to get the word out. We need to modernize the staging system. Everybody needs to be on the same page. It can't be just 2% of us that are ahead of everybody else. That it just makes it so hard. It makes it so hard when the medical doctors don't understand different kinds of diabetic retinopathy. It just makes it so hard. And on occasion, they'll kind of mess up the patient's head. I'll be doing all these tests. I'm like telling them they got something wrong with them, but they don't have any visible vascular lesions. They'll go to their medical doctor. The medical doctor will send them to a retina specialist without telling me. I get a report from the retina specialist saying that the patient's normal. I'm like, what are you even doing there? I got railroaded by the medical doctor because they don't understand what I'm doing. So we got a long way to go there. That's why I usually don't mess with them. I just concentrate on my patients. I got them in front of me. They trust me. I'm trying to help them. They know that. And I can impact change and change lifestyles, change risk factors. I can do that face to face, one-on-one, because we have that opportunity as optometrists. So if they talk about glasses, I send them out to my optician. I got 2 contact lens techs if they want to get some contacts on. I don't do none of that stuff. I talk to them about this kind of stuff because this is what I can do that the rest of my staff can't do. So that's for people that are listening, if you want to try to kick it up a notch, that I think you got to talk to them, and this is what you talk to them about, the stuff we've been talking about tonight.
Well, I want to thank Dr. Craig Thomas for joining me. I really appreciate it. If people want to find out more about you, how could they do it?
I'm in Dallas, Texas. I think I have a small internet presence. If you go Craig Thomas, Dr. Craig Thomas, I used to do a radio show on the gospel station. They call me Brother Craig sometimes. Just I can be found. Craig Thomas in Dallas, Texas.
And if they want to get that off-label treatment for macular degeneration, how would they do that?
Well, I mean, again, any technology that can provide legitimate photobiomodulation therapy should be able to produce results. And again, and I've seen at least 3 different devices that can do it.
If they want to
There's
come to
probably
you
more.
if they want to come to you and get it, how could they do that?
You mean like watch it or what? I don't sell
No,
it.
no, they want to come and be treated by you.
Yeah. I mean, just call and get an appointment. Yeah, yeah. See, I mean, we get 2 or 3 people a day.
Well, I
Yeah,
really appreciate it, Craig. You're a wealth of information and you're really a great guy. And I appreciate you sharing your knowledge with us.
You're welcome. You're welcome. Glad to be here. Thanks for asking me.
Thank you. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MySight one day the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.